Antidepressants. What nurses need to know. Prevalence of depression is on the increase in Australia. Approximately 9% of men and 15% of women are affected. The rates are increased in consumers with chronic illness such as heart disease, diabetes, cancer, and chronic obstructive pulmonary disease. Physical and pharmacological causes of depression include cancer, infection, electrolyte imbalance, neurological disorders, Addison's disease, autoimmune disease, and pain. Some prescription medications may lead to symptoms of depression, such as steroids, digoxin, beta blockers, and benzodiazepines. Consumers who are considered to be at a high risk of suicide are generally not prescribed antidepressants, which may lead to toxicity and subsequent overdose. For consumers at risk of suicide, selective serotonin reuptake inhibitors are considered to be a suitable first line of treatment. Commencing an antidepressant. The type of depression needs to be considered before deciding on a course of treatment. Mild to moderate depression may respond well to non-pharmacological treatments, such as cognitive behavioral therapy. However, some of the rarer forms of depression, such as melancholic or psychotic depression, will often require pharmacological treatment. Other considerations include, but are not limited to, factors that may have contributed to depression, for example, biochemistry, the death of a loved one, or chronic illness. Drug and alcohol use, other medications the consumer may be taking, social support and networks, accessibility to support and treatment. In treating depression and/or commencing an antidepressant, a multidisciplinary team approach is recommended with specialists who are experienced in the treatment of mental illness. An assessment of the consumer ought to be undertaken by the registered nurse. Vital signs and a fluid balance chart, bowel chart, body mass index and sleep patterns, behavior of the consumer, hepatic and renal function, and serum creatinine and urea levels. Severely impaired liver and renal function is contraindicated in the administration of antidepressant medication. Consumers with epilepsy, hypothyroidism, and history of cardiac disease need to be cautious, as antidepressants can aggravate these conditions. Adherence. Are patients going to take their antidepressants? For approximately 45.9% of the community, the answer is no. The reasons for non-adherence to pharmacological treatment of depression are as follows: the side effects of the medication, stigma associated with depression, the mental state of the consumer. The consumer felt better, so ceased their medication. Affordability. The desire to solve issues without the use of medication. Fear of dependency. a lack of support. There may be many reasons, and often multiple reasons, why patients ceased their medication. This is a sample of the most common reasons reported by patients. Among the many unwanted side effects of antidepressant medication, sexual dysfunction is considered by consumers to be a priority in ceasing medication. Why is the subject of adherence clinically significant? 74.5% of the consumers taking antidepressant medication stated the reason for non-adherence was that they forgot. These statistics indicate the significance of the registered nurse supervising consumers as they take their medication. Medication and psychotherapy. When not used in conjunction with psychotherapy, pharmacological therapy has a low adherence rate and low success rate in the treatment of depression. Some cases of depression may indicate medication treatment in addition to psychotherapy. Evidence-based studies have shown that a combination of both therapies can greatly improve consumers' adherence to taking antidepressant medication and thus better patient outcomes. Medication titration. Titrating to the correct dose improves consumer adherence. The aim of titrating antidepressants is to achieve an optimal and beneficial effect for the consumer while keeping unwanted side effects to a minimum. Titrating the correct dose of an antidepressant may require multiple medical appointments and follow-ups. Social factors relating to psychotherapy and titration. Doctor's appointments may be costly. Not all patients will be able to afford the medication, let alone multiple appointments. Accessibility. Can the patients get to the appointment? Do they live rurally? Can they drive? Do they have access to transport? Social support networks. Does the patient have a social support network? These are all risk factors for non-adherence. Side effects and withdrawals. What to look out for. Psychotropic antidepressant variety. Hungerford et al. Relay the following varieties. Tricyclic antidepressants. Selective serotonin reuptake inhibitors. Serotonin noradrenaline reuptake inhibitors. Noradrenaline and specific serotonin antidepressants. Noradrenaline reuptake inhibitors. Tetracyclic antidepressants. And melatonergic agonists. The following side effects of antidepressant medications are listed by Hungerford et al. Dry mouth, urinary retention, blurred vision, constipation, sedation, sleep disruption, weight gain, headache, nausea, gastrointestinal disturbance, diarrhea, abdominal pain, inability to achieve an erection, inability to orgasm, sexual dysfunction, agitation, and anxiety. Psychotropic antidepressants, an overview on tricyclic and inhibitors. Tricyclic antidepressants may result in toxicity. Here are some side effects of impiramine. and Sinequin. And Allegron. Serotonin norepinephrine reuptake inhibitors. Here are some side effects of venlafaxine. Selective serotonin reuptake inhibitors. Here are side effects of fluoxetine. Monoamine oxidase inhibitors. Here are side effects of moclobemide. Extrapyramidal side effects may result from monoamine oxidase inhibitors characterized by Parkinsonism, dystonia, akathisia, and/or tardive dyskinesia. Drug interactions. Monoamine oxidase inhibitors are contraindicated with other antidepressant medication and may result in fatalities. Benzodiazepine's half-life may be increased. Warfarin may increase excessive bleeding. Phenytoin and other anticonvulsant medication may increase toxicity. Antipsychotics may cause risk of sudden cardiac death. Withdrawals. Abrupt cessation of antidepressant medication may result in the following symptoms: headaches, nausea, vomiting, abdominal pain, diarrhea, insomnia, nervousness, anxiety, a general feeling of discomfort, delirium, tremor, agitation, and may prove fatal. Suicidal ideation, stigma in relation to depression and antidepressants. There is a greater risk of suicidal ideation in the early stages of the commencement of antidepressant medication, which has been linked to elevated energy whilst depressed mood remains. It is therefore important for the registered nurse to understand the risks of the consumer in commencing antidepressant medication and to inform the consumer of the associated risks, including potential increase in suicidal ideation upon the commencement of antidepressants, the danger of abrupt withdrawal, and side effects and interactions, for example, alcohol or St. John's wort. Parasuicide. Parasuicide is an attempt at suicide that does not eventuate in death. Most parasuicide attempts are not violent. Generally, they involve self-poisoning. 67.37% of females attempt parasuicide before 30 years of age, and 60% of males after the age of 30. One of the major problems associated with tricyclic antidepressants is their potential for toxicity and overdose. Second-generation antidepressants have proved just as effective and less toxic. A recent study revealed a decline in parasuicides among those taking selective serotonin reuptake inhibitors. Antidepressants should only be prescribed if the depression is moderate to severe. Advise the consumers of the dangers associated with antidepressants. A recent study found that parasuicide attempts are more likely to occur within the first month of commencing treatment. This highlights the importance of closely monitoring people who are taking antidepressants. If the consumer has a history of past suicidal attempts or suicidal ideations, this requires immediate attention of the registered nurse. Shame and stigma surrounding depression. Stigma related to mental health problems can be divided into perceived public stigma or stereotype awareness, personal stigma or stereotype agreement, and self-stigma. Overcoming stigma. The need to diminish stigma ought to be disseminated. Many people hesitate to use mental health services because they do not want to be labelled as the mental patient and want to avoid the negative connotations of stigma associated with depression. By actively listening, showing respect, avoiding personal judgment, and remaining focused on the issue, one may empower the patient to engage in their treatment. The following resources may prove useful for consumers experiencing depression. AusHelp Foundation at aushelp.org.au, Beyond Blue at beyondblue.org.au, the Black Dog Institute at blackdoginstitute.org.au, and Lifeline on 131114.